Hello, my name is Alexander Antipov. I'm the director of the Corrective Jaw Surgery Center here in Roseville, California. And treating jaw surgery patients is my true passion, and that's what we specialize in. We handcraft every case, plan it meticulously, and get a definitive result for patients.
So goals of treatment for the orthognathic surgery, and orthognathic surgery the goal is to make the jaws straight. That's where it comes. Orthognathic is the jaw, ortho straight jaw, for the lack of a better term. So the goals of the treatment for the jaw surgery: stability, facial balance, stable occlusion, gum health, team J health is very important, improved airway, and patient satisfaction. Can you see well? Yeah? Yeah, okay. So everything starts, most of the time it's orthodontic consultation. That's where it starts from. Orthodontist initiates a referral of some sort or concern about that the patient may need a jaw surgery. It could be in the general dentist office. If you're doing Invisaligns on your own, then that could be a case. But typically, somehow patients get to the oral surgeon, and we do the consultation for them. And it's about an hour and a half consultation. In my office, I usually do them at the end of the day, so I have nobody else scheduled. We just spend a lot of time with the patient talking. There are a lot of things happening during that consultation. We'll talk about it in a second. Then we follow with orthodontics, probably 6 to 18 months approximately, and then we do a surgical workup approximately 1 month prior to the surgery, and then there's a surgery, recovery, and post-surgical orthodontics, anywhere 6 to uncertain amount of months as needed, but typically around 6 months, and then retention, lifetime retention. A variety of deformity from dental hygiene schools and dental assistant schools. We all know angle classification. Class 1 supposed to be ideal profile, which is actually not true. We'll find out that in a little bit. Open bite, orthognathic is the scientific term for that. Deep bite, high angle, low angle, that's the mandible angle if it's open this way. High angle if it's low angle, deep bite usually. Facial asymmetry cases are the most difficult to treat because then we're treating in 2 planes. Usually our asymmetric cases is two plane planning. Long face, short face. Long face is usually a little easier to treat than the short face, and some people have bimaxillary protrusion. Again, class 1, class 2, class 3 airway. Orthodontic preparation for orthognathic surgery. Huge. So we will discuss extraction, non-extraction cases. First or second premolar extraction is easy. Sometimes people, patient is scared of jaw surgery at all, or it's not even an option. Even if they have a slight deformity, they have declined profile, but they just want to bite. And premolars are extracted, and that helps orthodontists to align the arches. Mandibular incisor sometimes has to be extracted. That's the second most common tooth. Am I right, Dr. Nolan? Yeah, mandibular incisor. And then we do third molar extractions as well for those patients. For non-extraction cases, which are becoming more popular now because it gives you a full set of teeth, palatal expansion, which is called SARPI, which we surgically expand the palate with the teeth without doing a major operation. So it's I would say, not a fourth one, which is a major, but something in between. Then mandibular expansion sometimes needs to happen, and that can be a big surgery or less aggressive surgery with distractors, and then a distalization of the molar teeth with the tetrabolar plates, interproximal extension. So this is a lot of text here, so I want to kind of skip through that. First surgical consultation. So when the patient comes to this office, what do we really do on the first appointment? It's a medical history, dental orthodontic history. We do the cone beam CT scan, dental models, pictures. We do an exam, facial, intraoral, team J, 2D lateral cephalogram, which we extract from the CT scan, which called a true ceph. It's a really true cephalometric measurement. and then we establish diagnosis, treatment options, presentation to the patient, and recommendations to the insurance company and to orthodontist how to proceed. Then there's intermediate surgical consultation. Just involves diagnostic casts, usually every 6 months. As the patient goes through the ortho treatment, we just take impressions, see if they're ready. And then the final surgical consultation workup, where we do very advanced facial analysis, laser face marking, establish the head position more accurately, facial photography, 2D, 3D planning, and splint production for the actual surgery. We're going to talk about natural head position in a little bit. So in the lateral plane, we plan class 1, class 2, class 3 malocclusions, and facial asymmetry is in the frontal plane. So two frontal plane planning for symmetries and lateral for the just regular deformities. So the main question is, does the medical insurance cover orthognathic surgery? Because I often hear it, we didn't do it because medical insurance doesn't cover it. Yes, and most of the time it does. I would say 95 to 90% of the time it gets denied quite a bit. We have to do peer-to-peer reviews with the medical directors. If let's say it doesn't, then just change the carrier and other medical insurance will cover it. It's as simple as this. It might take another 6 months to get the benefits, but medical insurance has to cover this surgery, and we work hard to get it covered. All those cases you'll see, it's regular people who had an orthodontist, had regular medical insurance, and it's all got covered. So the first patient we're going to talk about, case 1, is the female of 24 years old, and she has a very close to class 1 bite. She has a little bit of distal occlusion, that means her lower jaw is back. She has facial decline, and when she smiles, she shows enough of teeth, but you can see here she has a retrusive chin, and not a whole lot of asymmetry. Her midlines are relatively leveled. When we look at her facial profile, it is important to put the head consistently in the natural head position. And one of the ways to do it is equilibrate the head position by doing certain movements, and then you have to look straight, not up, not down, just straight, and just like you're looking at the horizon, and you don't want to have a cant to the head. Sometimes we have to adjust head position for certain asymmetries. We like quarter views for cheek profile, smile views, and then we produce the CT scan with the airway. So now, before we used to just have a lateral ceph, now we have capabilities to do 3D scans. And this scan was taken in the scanner, and the patient was looking up. So it definitely has to be adjusted to the natural head position. So you see how much discrepancy we have? We have to rotate that image to plan correctly. So this is before and after surgery. You can see the soft tissue profile change is double jaw surgery. We have upper fork 1 osteotomy. We have lower bilateral sagittal split osteotomy. We have chin advancement via genioplasty, advancement and downgrafting. And we have probably about 6 degrees of the occlusal plane rotation. So the key to get this chin out, you can't just bring it out, and you cannot do too much of advancement. So usually we like to do about 2 to 4 millimeters of the osteotomy on the chin. And sometimes we have to do more, but it's better to do less to have a nice ligamental fold, which you can see. This is the rested position here for a patient. So the profile drapes around the bone nicely, and you can see the increase in airway. And the pogonium came forward 25 millimeters for this patient. So this is the occlusion after the surgery. So we kept the midline straight. This is the profile change. 3/4 views. A lot of patients, they look for cosmetic result as well, and they would like us to enhance their cheeks. A lot of women like big cheeks, and that's what we do. So this patient got cheek implants. We did revised her nasal base for better nasal projection, and we did the lip reconstruction. So again, this is her preoperative mouth opening. So I showed you the final result. Now we're going to talk about the problem that this patient had. She had very close to class 1, but she had severe TMJ problem. So she couldn't open. She had severely resorbed condyles. They were like a drumstick. If we look at the TMJ health, so those patients, especially females, I mean only females, get that problem. It's called estrogen-associated condylar resorptions, idiopathic condylar resorption. We do get estrogen levels for those patients, and you can get a patient with a full mouth veneer reconstruction that will get a facial decline like at 17 or 18 years of age, and you have to look for this. So if you see somebody who's retrognathic and they want to improve their appearance via full mouth restoration or orthodontic treatment, you have to catch it early. Simple tomograms like this will show a lot. And what is the differential of condylar remodeling? Functional remodeling in class 1 bite is maintained. So that's maintained. This is what this patient is. Or dysfunctional remodeling when it results in class 2 bite. That means the patient slipped. And I will show you that in a few cases after, there's a patient who had class 1 perfectly done by distinguished orthodontist, and she slipped. And she slipped when she was 17 into severe class 2 malocclusion open bite. And part of that probably was her estrogen. So dysfunctional remodeling, also synonymous with idiopathic female condylar resorption. That means that etiology is unknown, but hypothesis that estrogen is the problem, receptors estrogen, and then resorbs the condyle. Idiopathic condylar resorption, progressive condylar resorption of vascular necrosis. TMJ protocol for us here, and this is just a small number of things we do preoperatively, but we start a year to 6 months. We medicate those patients. We medicate condyles with simvastatin, omega-3, doxycycline. Sometimes we put them on anti-inflammatory Feldin, vitamin E, C, and anticonvulsants, amitriptyline, and sometimes in permanent salt diet. They do get splint therapy of some sort and Botox injections. So again, let's look at the patient profile with the 3D. So we use the titanium plates and screws, and with a big advancement like this, we double plate, because this is from here to here, it's osteotomy gap. It's very big. It's probably 12 millimeters. But if you get 12 millimeters here, it doesn't mean you're Pogonian, which this point right there. Can you see the mouse when I do this? Yeah. This is Pogonian. This is the most anterior point of your chin. This one actually came on this patient probably about 27 millimeters, so more than an inch forward. So how can you get that inch? You can't do it by just sliding jaws like this. You have to change occlusal plane. You have to rotate the face this way and get the chin by counterclockwise occlusal rotation of both jaws, and that will kick that chin forward. So that's history, but I have to show this. This is the face bowl, so you can realize how bad that retrognathic is, because patient is in the splint, and that's where the joints are seated now, and she has a face bowl. So she has a face bowl, and she stands in front of the door. So I'm looking for the vertical lane, and I have a grid in my hand, and I'm looking to make sure her true vertical plane of her face, which is the abbreviation is TVL, true vertical line, which is run from subnasally, and you can see that line right there. I run it through the nasal base right here, and I want it to be probably about 4 millimeters in front of glabella. And then this is our true head position right there. And I put that articulator bar parallel to this string right there. So I have a grid in my hand, and I'm standing, and then the picture is taken from behind. So we're going to take a look at the occlusal cants as well. And there's another picture there. So you can see there's my hand right there. There's my finger holding that grid, and I'm just checking for face this way. So again, This is her preoperative profile. This is surgical planning on the Dolphin imaging software. So that's how we planned. And that's what we got. So pretty much we can get very accurately right now because everything is handcrafted. Every case is handcrafted. And now it's even more accurate and predictable with the 3D planning. So this is still 2D. I had to cut the models, I had to articulate them. We don't do this anymore. I'll show you how we do it now. It's all 3D, just like you take digital impressions for, instead of impression materials in selected cases, we do that with the 3D planning. And that's her third week after surgery, and those patients with those very funny TMJs that are drumsticks, you have to establish the TMJ protocol early. What does it mean? You have to mobilize them. You need to make sure there's a hydraulic pressure in the joint, bringing oxygen, and it's healing. They always on tetracycline. They always Botoxed heavily in the masseters and temporalis because we don't want any parafunctions of the masseter. And they always have class 2 elastics of 4 ounces, and they always have skeletal fixation. So what helps now, let's go back to this 3D picture. You see those screws sticking out of the jaws right there? Those are TEDs. It's temporary anchorage devices. And so we put elastics on those TEDs instead of putting them on the braces. So that makes the facial traction. And there are lots of nuances, and these are probably the most important: is early mobilization, medication, soft diet, and skeletal suspension. So it's like belts and suspenders. So again, this is 3 weeks after surgery. We can see profile improvement. This is the bite after braces are removed. This is the face before and after. So we can see the chin point came probably right about there, because those images are consistent. So her forehead, her inclination of her face is exactly the same, and you have to adjust it. So now we use, when we scan, we put facial markers on. So when we scan, put the image on the cephalogram tracing for 2D and 3D planning. Everything is in the natural head position. So this is important. So obviously, patient improved the facial balance. You can look at the airway. So upper jaw forward, approximately 5 millimeters. Lower jaw forward, perfect occlusion, and a lot of counterclockwise rotation of the face. A lot of counterclockwise rotation of the face.